Good morning. Thanks for viewing my channel. Recently, I have been adding CNS cases. With the interest, they were interesting cases. Got admitted to our hospital, and last video which I put was on the localization of a spinal cord lesion. But today I thought, taking a break from the CNS cases, I would give you a short case which is very interesting. Probably in your career you would see once or twice, but how to discuss those cases, because if it is there in the exam, in the board, as I always say, this will also be put in the examination. So this is a child who came to us at about 2 months of age, and when the child came, there was a history of jaundice which the parents noticed at 15 days of age. The child was born to I think a third gravida mother, normal delivery. Weight of the child was 2.6 kg. So it was a term baby, 2.6 kg, delivered in our hospital only, and was handed over to the mother after a day or so. So it was uneventful. The delivery was uneventful. Went home. The child was doing well, taking breastfeeds well, and at 15 days of age, the parents noticed that the child is looking little ectric. Then they took the child to a quack, and as most of the families we have that jhada, so that jhada was done, and some indigenous medicines were also given. The child, along with the jaundice, they noticed that the child had some acolic stools, but after giving those indigenous medicines and the jhada, they say that the stool became colic, but jaundice did not improve. So they went from one doctor to another doctor, but the jaundice would not improve. So they came to us at about a month of age. The child has been with us for about 25 days, and when we saw this child was a term baby. Icterus was there, active, taking breastfeeds normally. At that time, there was history of course, passage of a high colored urine, but no history of any passage of the acolic stools. Now, after 2 weeks of age, if I ask you, as per the definition, which you people all must be knowing, that it is a case of a neonatal cholestasis. Now, for the definition of cholestasis, we got the LFTs done. LFT revealed initial LFT was bilirubin was 7.1, and the direct component was more than 50%. So that means 7.1 and it is 4.3. So it's more than that. OTPT, SGOT was 101, SGPT was 30.8, serum albumin was normal. Kidney function test was also okay. So if I ask doctor, she is sitting in front, so Dr. Archana can ask, what is the definition of what this looks like a direct hyperbole.
Direct hyperbole.
So what would you like to say? Is it a case of a neonatal cholestasis?
Looks like neonatal cholestasis.
What is the definition of the?
Sir, if the direct bilirubin is more than 20% of the total bilirubin, then it comes under the definition of direct comes under the definition of
cholestasis. So it has to be direct hyperbole.
Direct hyperbole.
So once it is very clear that it is not an indirect hyperbole. Had it been an indirect hyperbole, what you would have thought of?
So hemolytic causes I would have thought of.
You would have thought of more of the blood disorders, because the liver disorders will not cause the indirect hyperbole. That's right. So it was a direct hyperbilirubinemia. The child what all differential diagnosis, Pankhudi can definitely tell me, because she has worked in neonatology, what are the causes of direct hyperbilirubinemia at the age of around 2 weeks of age. You can keep and speak in the microphone.
Sir, it could be congenital hypothyroidism.
Right, so hypothyroidism is one, very good.
Any torch infections.
Torch infections, yes, very good. So torch infections, congenital hypothyroidism. This is what you have come across in the nursery. Any uncommon causes, Tanu can say?
Sir, biliary atresia.
Yes. So neonatal hepatitis and biliary atresias, yes, you have to keep in mind extrahepatic biliary atresias. Well, it is very difficult, but in biliary atresia, just by it is one of the causes of neonatal the neonatal cholestasis. Anything else? These are the common causes, but I think for the sake of good discussion, we can divide it into, so that we don't miss it commonly. One is the outside the duct. When you are examining this child, I did not give you the examination. When I examined this child only had the liver, which was 2.5 centimeters. No spleen was palpable. No other mass in the right hypochondrium was felt. Why I am asking is, sometimes choledochal cysts, so external compression can also cause, so that is structural anomalies. So after that structure, you come on to the hepatitis or infections. Common things is the infections. So common one infection, as Dr. Pankhudi said, one infection is your torch infections. The other thing is a sepsis per se. And I was just reading, sometime it is mentioned that you have to find out extreme, if there has been a hypoxia. So if there is a neonatal hypoxia, that sometimes can give rise to hepatitis. It is mentioned in some of the books. So there was none such. What else? The other thing is you have the hepatitis, extrahepatic biliary atresia, sepsis, then the uncommon causes, which are the metabolic causes. So metabolic causes, of course, will be, you should keep in mind and then try to negate it. One is the galactosemia. So galactosemia will present much earlier, and because the child was on mother's feed, the child will have nausea, vomiting, the child will have not doing well, not feeding well. So those were the things which you would like to keep in mind. So one is galactosemia. The other thing, uncommon causes will be what other metabolic causes you would like to say? The other metabolic causes are, okay, tell me Pratik.
Sir, galactosemia, Niemann-Pick disease. Then
so the common things will be these things are present little late, like hereditary fructose intolerance, tyrosinemias. They usually present after a few months. So you must know that at 2 weeks of age, they are usually not the causes. So alpha-1 antitrypsin, though it's not very common in India, I have not seen any case. But yes, if you should keep those things in mind. Somebody, when you are giving in the exam, they can ask you the common causes of neonatal cholestasis. So these are the few causes. So metabolic is one, structural one, sepsis and torch infections. So most important thing in our setup will be the torch infections. So that is what we would like to keep in mind. So I like to say that this child had involvement of the enzymes were quite raised. The child was with us and we were trying to investigate. At that time the ultrasound of the child was normal. So there was no external compression. Ultrasound was normal. Then we repeated after about a week's time the LFTs, and LFTs had further deteriorated. LFT was, now the total bill was about 8.36, the direct was 4.62. SGOT 101 earlier, now it is 113, but the SGPT, which was only 30, had gone up to 300. So that means some the enzymes had further deteriorated. It worsened. Keeping those things in mind and the torch group of infections, we thought of of course we like to send the samples for the cytomegaloviral. In our setup it is pretty common. Before sending along with the investigations, we got the fundus examination also of this child, and there was no evidence of any chorioretinitis. So there was no chorioretinitis in this child. I said liver was only palpable. Child was awake, taking feeds well. Now, when we got the cytomegaloviral, before that we sent the serology. Serology of this child for the torch, the cytomegalo was also okay. There was no IgM antibodies against the cytomegalovirus in the child. But then I spoke to some people at AIMS, and then we tried to send these samples for the urine examination for the viral studies. Now here there is a catch. If I ask you, Dr. Divya is also here. So if I ask you that at 3 weeks or 4 weeks of age, this child had come to us at about 1 month. And while we were sending, 15 days already passed. So at that point of time, would you like to send only the urine sample, or you would like to send some more sample?
Sir, we can also send blood sample.
Why should we send a blood sample? Very important, you are right. That is what we did. And having discussed it, why this is important, which you should know in the discussion, that when the child is born, the child could be having a congenital cytomegaloviral, or it could be an acquired viral cytomegalo. Because as the child is born, now child spreads by your saliva. So somebody is kissing the child, it can be an acquired cause. So after 3 weeks or 4 weeks of age, it is difficult whether the child has acquired the cytomegalovirus or the child has got a congenital cytomegalovirus. So for that we sent as you rightly said, we sent the blood sample also along with. And you would be surprised that the cytomegaloviral disease was positive, and the viral titers were pretty high in the blood. They give the report as for urine CMV positive, and for blood the levels were, I think I'll just give you the levels. The plasma levels were 1.8 into 10 raised to the power 4 units per ml. That is 10 raised to the power 4. I talked to the lab people, they say it's pretty high. It has got some implication which I am going to talk to you. So now this child has got positive CMV. What are the points now against this child? Never had any the chorioretinitis. Now for the congenital CMV infection, then we even got the one thing which is important here. Somebody can point out, this came in my mind also, and somebody can ask me this question, that if the child has got an active infection, the child's CMV serology against IgM should have been positive. But in this child, as I said at the outset, the CMV IgM was negative. Now what is the explanation for it? Anybody can say? You see, the implication of this is whether this child has got an active infection, or whether this is just because, you see, cytomegalovirus can be just virus can be excreted out, or it is not a reactivating disease. But if it is present in the blood with high titers, it is suggestive of that it is a reactivating, it's a systemic reactivating disease, and then we have to find it out along with the clinical findings. And clinical findings in this child had hepatitis. So this child has got the CMV disease. But in the CMV disease, as I said, ideally IgM should be positive. But IgM was not positive. The explanation for it could be that the children or the newborns are immunologically little immunocompromised. So maybe it has not been able to raise the antibody levels to the 90% of the time you will have positivity, but 10% of the time you may not have CMV IgM positivity. So that is what I personally, this explanation is there, that the CMV IgM is not there, but then the virus is being excreted and is there in the blood. So this is a child of, इसको लेटा दो एक बार, आप बच्चे को फोकस कर सकते हो. So this is a child who has got liver palpable. There is no spleen. Liver is about, yes, well, liver is about 2 centimeters. Yes, it's more than that. 3.5 centimeters. The rest all is not there. Uthalo. Now, there are few things against also, which I must discuss here. This child is not an IUGR. So, this is a term baby. So, that is one thing. This child is, so there are certain things against also. We must discuss the pros and cons. A child, usually cytomegaloviral disease, a child should be born either a IUGR baby. There should be other problems like thrombocytopenias or microcephaly, which this child, we have measured the anthropometry we've done, there is no microcephaly, there is no spenia, cytopenias, thrombocytopenia. So those things are quite against. I mean, normally we tell in the exam or we tell the students that these things are there in the cytomegalo. Can Pratik, you tell me which, usually you have microcephaly. What happens, can there be hydrocephalus in torch infection? Can be. So which disease you would like to keep in mind? This is a very common question I ask in the exams. Toxoplasmosis. Toxoplasmosis can have the even hydrocephalus. So usually you have microcephaly, but you must keep that thing in mind. So that is one thing. So this is a child, we have got a child of a congenital cytomegaloviral disease. Blood positivity, as I said, is a systemic disease. Hepatitis has been found out. So what will you like to do? Anything else? HIDAS can be the talk of. We did the biopsy also of this child. And the liver biopsy of this child has shown us. Would you like to say what biopsy will be there, Abul? Biopsy, can you say something? You see, this child, we have to do the biopsy because very important differential diagnosis is extrahepatic biliary atresia. So when we did a biopsy has come little up, though it is invasive, but then it tells you the giant cell hepatitis. So what is happening is 2 or 3 cells coalesce together and they call it a giant cell. So this child has got giant cell hepatitis, which I found out from the pathologist. There is no biliary lakes or biliary plaques. That is, there is no evidence of extrahepatic biliary atresia, which you can find out by doing a biopsy. So that biopsy is also telling us, you see, if the child, one more important thing you must know in the examination, if the child is well, the child has got jaundice, child is looking well, enzymes are more or less normal, this is more pointed towards the extrahepatic biliary atresia. So what is happening is after few months of age, 4 months or 5 months of age, when there is extrahepatic biliary atresia, there will be increase in the transaminases only after a few months. At the outset, if you have got the OTPT raised, this is a pointer, and it had worsened also over a period of time. This is a pointer more towards the neonatal hepatitis, and it has been further corroborated by our biopsy also. Other thing, when I was talking to some of my colleagues in microbiology, they said, though we have done one biopsy, there is a possibility that even you could do a PCR from the liver tissue for cytomegalo. But then we need not go, just for discussion, we did not go into those details. So this is a case of a congenital cytomegaloviral disease. Extrahepatic biliary atresia has almost been ruled out. Other metabolic causes we have discussed. Now, if you have got this kind of a disease, what would you like to treat this patient as? Vaishnavi?
Sir,
Sorry.
vitamins, the fat soluble vitamins.
Yeah, very good. Fat soluble vitamins need to be given. That is one which we are giving. A, D, E, K. Yes. So that is being given. Anything else?
Sir, zinc.
Sorry.
Yes.
What for CMV?
What for CMV?
IV Ganciclovir.
Injectable Ganciclovir.
Injectable Ganciclovir. So this is a child You already put this patient, you see, there are indications for starting this antiviral drug. If you have got isolated keratitis, if you have got hepatitis, which is, it's an activated disease, it's not the only excretion, or you have the cytomegaloencephalopathy. So if you have the CNS involvement, then you have to give the Ganciclovir. So Ganciclovir has been started in the dose of before coming I was also not knowing the dose also, 12 milligram per kg per dose to be given for about 4 weeks. After 4 weeks, in congenital CMV infection, we would like to continue oral drugs for a period of about 6 months. So we have luckily a drug called Ganciclovir, which is given after 2 to 6 weeks of the injectable IV Ganciclovir. That is what precisely we have planned. We have already started this child on Ganciclovir. We will monitor the liver functions every weekly, and then we will see. So that is what I have dwelled more into the congenital CMV infections, neonatal hepatitis. So if this kind of a case is there in the ward, it will always be kept. So you should know about the case. Thank you very much. Any questions anybody wants to ask? You have not asked any questions. So either you have understood everything or you have not understood. Abul?
So what are the complications that we can expect in such a case? In case of congenital CMV infection, if we send the child home?
Supposing we send the child home, this child will go in for a hepatitis is there, liver cell failure, bleeding, the child can have hepatic encephalopathy. So that could, yes, important things in the causes I have not mentioned, which I should have mentioned much more. In spite of all the gamut of investigation, there is a very big chunk of idiopathic neonatal hepatitis. We don't find out the cause, and they do settle down after a few months of the your vitamins, they do settle down. So this could be the other important causes, idiopathic. So 20-30% you have cytomegaloviral. You have also got the causes. I have sent the samples for hepatitis viruses, hepatitis A, hepatitis B. So, sorry? That is also one important cause. Yeah, that is also one of the causes for the sake of discussion, you rightly said. So as I said, you may not find any cause and idiopathic, so we give a chunk of idiopathic hepatitis. That's all. Thank you very much.